So thank you, Dr. Ullman, for being here today. And I guess I will give you the floor.
The audio's mute. I'm fine. How anyone can hear me?
Yes.
All right, perfect. Okay, just want to make sure that we're okay. All right. Well, welcome everybody. Delighted to be back giving this talk for the Brain Turns. And it's a really great program, a great opportunity to really get an essence of what neurosurgery is all about. So, and one of the things that we do is trauma. So neurotrauma. I'm going to talk about traumatic brain injury and head injury because this is a very important aspect of what we do. It can, I think that there may be developments in all fields, but unless we have great and even foolproof injury prevention, injuries will happen and patients are going to be presenting to us with the need for neurosurgical evaluations. So, it's not always easy for all of us. Trauma can be quite difficult, actually. So there are different types of head injury. There's a blunt, penetrating, there's open, there's closed head injury, there's mild, moderate, and severe. So it runs the gamut. And there are common causes, which are motor vehicle crashes, pedestrian accidents, assaults, falls, gunshots or stab wounds, firearm injuries. It's been really a hot topic these days, and Northwell is leading the charge in trying to come up with ways to prevent firearm injuries and occupational injuries and non-accidental traumas, such as not only child abuse, but also intimate partner violence can be included in that as well. The diagnosis of head injury is very important. When a patient comes into the emergency room, we have to examine our patients, their level of consciousness. We look at their motor responses to see whether they're actually moving reflexively or they're moving purposefully or following commands. We look at their reaction to the pupils to light. So here we have on the left-hand side, we have a blown pupil in the patient. So that's going to be an important sign that maybe something's going on in the brain. Could also be ocular trauma too. And we have to look at their ability to talk, whether they're oriented to self, place, or time, and whether they're able to breathe and how they're so basic ABCs of resuscitation, airway, breathing, and circulation always applies in these cases as well. So the Glasgow Coma score, and we're looking at just recently we celebrated the 50th anniversary of this well-known score in medicine and especially in neurosurgery. If you mention a GCS to a neurosurgeon and you say a patient is a GCS of 8 or a GCS of 4, they will have a picture in the mind as to what that looks like on the patient. And it really assesses the level of degree of injury, but not only that, but also the level of consciousness of the patient. And it does actually correlate with outcome. The lower your GCS, the worse the prognosis for a functional recovery. But we are, trying every day to try to help people recover from their injuries as best we can. So we have a Glasgow Coma score consists of 3 components. One is the eye-opening component, where you have a spontaneous eye opening. You have the response to eye opening to speech. So somebody says, "Open your eyes," and they do, or they call out your name and they open their eyes. And then to painful stimulus, somebody calls out, tries to pinch or to give supraorbital stimulation, and then that can open the eyes. So that just depends. The more comatose a patient is, the less they're going to do these things. And so there's never a 0 in the scale. No opening the eyes is a 1. So for the second one is a motor response, and this is really the most important component actually of the Glasgow Coma score because this is the one that has the highest level of correlation to outcome. And so it goes from a 6 of obeying commands to 5, which is localizing. That means if you give a pinch, someone's going to actually try to reach up and swat your hand away. This other thing is also crossing midline. So if you pinch on the left shoulder, perhaps, and the right hand crosses the midline to push it away, then that's pretty clear that that's purposeful and that uh, essentially indicates that there's a level of awareness on that on the part of the patient that they know something is there. Withdrawing is also a level of awareness, but it's sort of a lower level of awareness of cognition. So somebody presses on the nail bed and they pull away. Yes, they know that you're doing something, but that's a less amount of awareness than localizing. And then for an extensor response, I'm sorry, the flexor response is actually a 3, which is a little higher score. That's now getting into a reflexive response, which is more or less brainstem function. In the upper brainstem, if you still have function of your upper brainstem, but your supratentorial or cerebral cortex is severely impaired, then you would get this flexion response. And, or so we had called it in the past, decorticate posturing, but saying minus the cortex, decorticate. But so that means that the brainstem is functioning well, but there's very little to no cognition. And then that gets a 3. And then the last motor movement that gets a 2 is called extensor response, where the patient is actually extending their arms and actually pointing their toes forward. And that's an extensor response. And that indicates that there's function only really at the lower portions of the brainstem. And so that used to be called decerebrate, meaning that you're without your total brain, but it's actually there is some brain function, although it's at the highest level of coma and the lowest level of functioning. And then 1 is no response at all. And so here's an example of doing some noxious stimulus on a patient, and that patient is sort of flexing at their elbow. So we don't know from this static picture whether that's going to be a localizing response or a flexor posturing response. I'd have to give you a video to show you more, but sometimes it's not that clear. So the Glasgow Coma score is really not perfect, and nothing is perfect in medicine, but it's pretty well established in our vernacular, and we're able to get a sense of how people are doing. The verbal response is the third component of the GCS, and this is really to assess a person's awareness and orientation. If they're able to speak and tell you that they're oriented, then that's 5. Now, this is 2011 because that's the last time I modified this slide. But if you say, what year is it? And they say 2025, then you're saying, wow, that person knows at least where they are. And if they're oriented to place and time and person, that's great. If they answer 1972, which definitely that's not the answer, then they're confused and it's a 4. But it's just a conversational confusion. They can actually answer somewhat appropriately, but they're just not fully there. However, if they say an inappropriate word, like you ask, what year is this? And they say mother, or they say no or yes or whatever, a word that's not a direct response, then that's called an inappropriate response, and that's 3. And then there's incomprehensible sounds, which is a 2. That means either a groan, a moan, or some sort of screaming, grunting. That could happen, and that's an incomprehensible sound. So that doesn't mean that they're not aware, but their level of awareness is really depressed. depressed, and then no response is none. Where it becomes kind of dicey is that if you have someone on a ventilator, how are they going to speak? Now, unless they're actually awake and on the ventilator and mouthing words to you, then you don't really know where their verbal is. And then we would say add a T to our Glasgow Coma score. So if someone is a 4, T, meaning that their Glasgow Coma score of 4, likely they're not going to be speaking to you anyway, but you don't know if they are grunting or groaning or incomprehensible sounds. Sometimes that can happen. Then you say it's a GCS of 4T. So we add up these numbers, and if the coma score, the E plus M plus V, is 3 to 15, then you can get on that scale. The lower number meaning the least amount of function, and the upper number meaning the most amount of function and awareness. So they're not in a coma at 15, but they're in a deep coma at 3. So this is how we break it down. There's a mild category, which is a Glasgow Coma score of 13 to 15, and that's about 80% of all the patients out there. About 10% of the patients fall into the moderate category, where a GCS of 9 to 12 indicates a more significant head injury, and they are likely to be less aware, having troubles with levels of consciousness and following commands. Then, as a severe traumatic brain injury is between the Glasgow Coma score of 3 and 8. That's also about 10% also of the population, so they're much less common to have a severe traumatic brain injury. But let's just say that this is a categorization that's simply ingrained in our vernacular as well. But we can say that qualitatively, someone who's a GCS of 15 who suffered a concussion, who doesn't have any structural brain injury on a CAT scan or an MRI, can have persistent symptoms for a long time. And that's not a mild injury to that person. That would be a significant injury to that person. So quantitatively, this is how we break it down, but qualitatively, there's a lot of blurriness across these categories. And so mild may not be as mild as we think it is. So what's important when we're evaluating a person with head injury is that we get x-rays well, let's just say this is also an outdated slide because I didn't update it to say CAT scan. Mostly what we do is we really do need to image the cervical spine because there's a 10% association between a head injury and neck injuries. So here's a person diving into a shallow water, which is something that you should not do. And that's why we have the Think First Injury Prevention Foundation from neurosurgery. You think before you dive into a shallow pool, because then you can get this terrible fracture and become quadriplegic. So anytime someone's coming in with a head injury because they hit their head on the floor of the pool, means that that we need to check their C-spine. So nowadays we get CAT scans, and that's very important. So the CT scan is really an excellent in detecting fresh blood in and around the brain, fractures of the skull and facial bones. It's fast and it's easy to follow over time. It really is the gold standard in acute head injury management because what we are looking for is to look for a quick, easy way to assess blood. In pediatric patients, because CAT scans, even though we have low dose CAT scans, lots of CAT scans could have a significant adverse effect on development and in developing potentially radiation-induced tumors down the line. It's not very, very common, but it can happen. So we try to do MRI scans, and there are fast sequences for MR scans in pediatric neurotrauma that can be used to assess for blood, such as gradient echo imaging and such, or susceptibility weighted imaging. So we can see those things more acutely on MRI, but it's not the best test for acute hemorrhage. So we need that. The best scan, at least for adults, in the first periods is a CAT scan, quick and easy. And even in our modern centers where we have all the resources as a level 1 or level 2 trauma center, we can get CAT scan of the head, cervical spine, and abdomen, chest, and pelvis, just so that we scan the body for any major injuries. And that alone will take probably 10 minutes, whereas a MRI may take a little bit longer than that to get those results. So you could do a lot. CAT scan with today's scanners takes about less than like two, 3 minutes. That's really how fast it takes. And that's really what you need. So here you're going to see a whole lot of CAT scans and very little of MRI. But what we have here is a depressed skull fracture. These are types of injuries that you see. Here's a person who was hit in the head with a chair, and he developed this, actually the leg of the chair. And this is what happened. He had this depressed skull fracture, and this is on the left side of his brain. So there's orientation for a CAT scan. The outer white is the skull. All the stuff of the gray is the brain. And the right is if you're looking at a person, the right is on the right side. The left side is on the left side is if you're looking straight at a person, their left, their right. There's the front is at the top, the bottom, the back of the patient is at the back. And then here we have stipplings of blood in the middle on the left side of the brain. So that patient actually presented with problems with speech. This is the patient, and this is a picture of the open skull fracture that the patient had, which sort of conforms to the size of the chair leg, and that's brain actually coming out. So we know that this has to be immediately fixed when you have CSF or brain coming out of a depressed skull fracture, and we have to elevate that fracture. So very important. So that's the fracture, and that's the resulting, that's the cause of that injury. So we also see epidural hematomas. Epidural hematomas is really not the most common injury that we see. Actually, the most common we get is something called subarachnoid hemorrhage, where we have a wispy blood around the surface of the brain. And then this patient also has some contusions, which is actually bruises on the brain. But this epidural hematoma occurs between the skull and the dura mater. And then the epidural hematoma is the red blood clot that's on the right-hand side of the patient, the left-hand side of the screen. And that's due to a fracture of the bone most of the time and a crack in the middle meningeal artery where you have, let me just see, let me try this laser pointer here. All right, maybe that'd be easier. I don't know if you see my arrow. So here is the middle meningeal artery, which is an artery that runs along the covering of the brain normally and within grooves of the skull. And if that gets fractured along with the veins beside it, then you can get bleeding into this area that will accumulate over time. And then the patient can herniate and develop a herniation syndrome here, where the brain stem is actually being compressed by the temporal lobe, which is right here. And this is called the uncus of part of the temporal lobe. And that's going to cause a blown pupil, which you see here in this diagram on the patient's right-hand side. It does come with a classic lucid interval, so a patient gets a concussion from the head strike and they could pass out, but then they can wake up. And then after a few hours, once this is accumulated to cause herniation, the patient becomes comatose, and it can be quite quick, the deterioration. So that's the classic lucid interval, although you can get that with almost any pathology of the brain, including subdural hematomas. And it doesn't happen in every patient, but that's what has been historically described in association with epidural hematomas. All right. I'm gonna go page down. Okay, so here's an example on a CAT scan is an epidural hematoma on the patient's left. So this is the left-hand side of the patient. Remember, front, back, right, left, and here's the epidural hematoma. It looks like a lens, like a convex, biconvex shape, and that's because it's limited by the sutures. The skull is a bunch of plates that get knitted together after infancy, and so this they fuse, and then the dura mater, which covers the brain, actually sticks up against the suture, and so it's very hard to dissect that off. So an epidural hematoma will be confined to an area between sutures. Now, there is something called a subdural hematoma, and that's between the dura mater, which covers the brain, and the brain itself. And there are these bridging veins that go from the brain, draining the brain, up to the venous system through the venous sinuses, which are in the dura mater. And these veins can get torn by sort of a shearing force, rotational forces because of an impact. And then that could cause bleeding, and that will cause a hematoma that layers over the brain surface called acute subdural hematoma. And this is what it looks like on a CAT scan. This is a very severe subdural hematoma. This is a patient who, on the left-hand side, you see this white, which is an acute blood clot, and also extends along the covering that divides the two halves of the brain. And then you see the brain itself. These are the ventricles, which produce and carry fluid inside the brain that bathe the brain, that bathes the brain and uh, takes away toxins from the brain. And you can see that these are markers of the midline. You see these on previous scans that we have a midline here. These ventricles are in the midline. And so now we see it very drastically shifted over towards the right-hand side. And that's because this is causing a tremendous amount of shifting of the brain, and that's going to cause herniation and coma. So it's very important for us to immediately take someone to the operating room to evacuate this subdural hematoma by removing the bone and removing the blood clot. So this is a surgical emergency. Sometimes, unfortunately, if people come in very bad shape, we may say that it's too late, and that has happened as well. But hopefully, we try to be aggressive on all the people that we feel that have the possibility of having to save their lives from these types of injuries. It's interesting what can happen to these acute subdural hematomas. They can just go away, but sometimes because there's the shearing forces around the brain, the patient actually could develop something called chronic subdural hematomas. So in the subacute phase, 1 to 2 weeks, you could see that these collections over the surface of the brain, you see them on the right side, on the left, where the yellow arrows are. And that's sort of isodense to the gray matter of the brain. It looks gray, just like this is the gray matter of the brain. And so you can tell sometimes it's hard to tell, but you could tell because the white matter, which is this darker gray line, is not coming to the surface of the bone. It's actually going short of that. So there's some mass there. Here it's a little more apparent. There's a little bit of hypodensity within the subdural. So this is a subacute, and then we get chronic subdural hematomas. This is probably one of the most common conditions that neurosurgeons see in their career, in their practice. If you're on call, and at North Shore, we could see upward to several a week, sometimes once a day, even maybe twice a day, somebody coming in with a chronic subdural hematoma, especially as someone ages and their brain atrophies. There's a more space between the brain and the skull, and so the draining veins are becoming more stretched, and that why over time these things can leak, there could be shearing injuries, and then cause these things to form because there's these potential spaces that are increased chance for older patients to develop these chronic subdural hematomas. And then many times they have to be drained with a burr hole, which is a hole within the skull. And other times we've been treating them with other types of therapies, such as embolizing the middle meningeal artery. We talked about that because if that gets torn, that causes an epidural hematoma. Well, it's thought that that artery may supply some of the blood to a sac around this chronic subdural hematoma. So picture a latex balloon, water balloon, where you have water and then you have the latex covering. You have that blood vessels going around that latex, and then that they can kind of bleed, microhemorrhage over time, and then cause these things to accumulate blood over time. And so the middle meningeal artery can maybe supplying part of that membrane that's around the subdural hematoma to perpetuate it. And by embolizing it, we've had some success seeing these things shrink with as an adjunct to surgery to reduce the recurrence rate of these things, because there's always a space. These brain doesn't necessarily expand back to the skull right away after you drain these hematomas. So something's got to fill the space. So there's a risk that these subdurals may come back and you need more surgery. Middle meningeal artery embolization as an adjunct to surgery has been shown to actually reduce that risk of recurrence, probably by half or a little more than half. So that's a great development. I've also treated these with steroid medication, depending on the situation and the medical condition of the patient. So we do have other methods of treating these, but if they're really causing a lot of pressure, like the one here on the left, I mean, or even both of these on the bottom, then surgery is the appropriate treatment for this. And we can have different types of injuries. And here is a cerebral contusion. This is a bruise on the brain. Could be a consolidated hematoma, could be just a little like dark spot, which is a non-hemorrhagic contusion, sort of like edema, but without the black and blue. But here we have, basically a brain black and blue mark. But these things can flourish and get swelling around them and actually cause significant problems. This might even cause speech problems, but if they don't need to be operated on, sometimes it's just best to leave them alone, because as they resolve on their own, people can regain speech function if that's affected, or even motor function, say if they're paralyzed on one side or have weakness on one side from one of these brain contusions, that actually can get better over time. So this is the skull base, and this is an important aspect of trauma, because here that there are ridges to the skull base. Here we have what's called the sphenoid wing, and here at the anterior portion of what's called the middle fossa, where the temporal lobe is. And then we have the petrous bone here, which has some ridging there. And then we also have the frontal bone here at the orbital roof, this is anterior. This here is called the cribriform plate, which is where the olfactory nerve comes through to the brain and goes down to the nose as receptors for smell. But here you see these waves and ridges over the frontal region. So these ridges, if a patient sustains an impact, the skull will stop moving, but the brain, being suspended in fluid, will just keep going back and forth in sort of a resonance until it stops. And that rubbing up against these ridges can cause brain contusions. So here's an example of somebody with subarachnoid hemorrhage, which is another very common type of blood to see. Sometimes we see little tiny bits, but here's an example of a person with subarachnoid blood. This actually extends as little fingers between the sulci, with the sulci between the gyri. The brain is full of convolutions. And then here we have a subdural hematoma on top of that. And there could be multiple types of injury here. You have a subdural on the right and an epidural on the left. So it things are not just what's interesting about head injury, because it's not like a stroke, even though I kind of view the treatment of traumatic brain injury and severe traumatic brain injury on a stroke spectrum, because a lot of the damage that can happen to the brain is related to ischemia or the reduction of oxygen to the brain. The brain injury is a variable uh, disease process. Each section of the brain may have different things going on with them, and in terms of the degree of oxygen supply, whereas opposed to a stroke from a singular artery that gets blocked off, and then you get an ischemic stroke, then that's a very singular process, and that is a very discrete process. So head injury is a very variable and multiple process, and that's why severe traumatic brain injury is very difficult to treat to regain, functionality because of that variability. So diffuse injury is where you really have a diffuse injury to the brain. This diffuse injury is a transient alteration of consciousness due to the impact to the head and can be associated with the normal head CT. A diffuse axonal injury is really when you have a longer period of unconsciousness. The CT scan could be normal, but, or just to have these little, contusions. Here's a deep contusion within the upper midbrain, and here's some basal ganglier contusions and some intraventricular blood, and one at the cortical medullary junction at the red arrow here. So that indicates that is a diffuse injury where the axons are kind of getting sheared off of the cell body, and so that's very could portend for poor prognosis or reasonable prognosis, depending on giving time for recovery. And this is an example of a pathological specimen of deep injury, and this is a bulb on the, off the axon, and here's a cell body, as it got sheared off. So that's an indicator of diffuse axonal injury. A concussion is something that a lot of people have experienced in their lives, and that's a type of mild traumatic brain injury. But it's something that we have to be able to recognize, especially in athletes, and um, people, even interestingly enough, people who are victims of intimate partner or domestic violence will suffer concussion symptoms that go unrecognized for long periods of time, because these are repetitive injuries to the brain. But putting repetitive injury aside for a moment, we still have, a hit to the head can cause any type of alteration in some functioning of the brain. Seeing stars. Interestingly enough, some people can get concussion symptoms without even having felt much of anything except some local pain after a head strike. And so it's interesting what a concussion is. It actually often resolves within a few days. But what really is a concussion? It's sort of like a brief episode of an energy crisis to the cells of the brain. And this is what ends up causing these symptoms over time. They can actually persist for many months. You get headaches, fatigue, you get paradoxical symptoms like sleeping more than usual, but having insomnia. So many different types of symptoms. But repetitive brain injury and chronic traumatic encephalopathy has been seen in sports and other types of repetitive brain injuries, especially diagnosed originally in boxers. And so that could be repetitive axonal stretching or deformation. And what it ultimately, the diagnosis is really here you have a patient here with extreme pathological specimen where they have this septum pellucidum is got a hole in it, like what's called a cavum septum pellucidum, and there's atrophy of the brain causing the ventricles to enlarge. That's a severe case of it, but often it's an accumulation of tau proteins, similar to what you get in Alzheimer's disease. So if patients in long term with chronic traumatic encephalopathy can develop dementia and type symptoms. So I'm not going to go too much over CTE at this point. We don't really know the full extent of it. And, just because you've had some concussion doesn't mean it's going to lead to a CTE profile. But we just need to know, and what's important is that many concussions, many head injuries can lead to downstream cognitive effects. So we have to be careful about ourselves and think about injury. This is an example of a penetrating injury. So you see the huge spectrum of injury that we've got. This is the exit hole actually on this patient. This is their CAT scan. This is the entrance. You see the bullet, the fragments are coming in this direction and came out this forehead exit hole here on the left-hand side. And so that's that's an injury. These are survivable. We don't go chasing after these fragments, but we can clean these out, wash out these wounds. If a patient needs intervention because of a hematoma or disrupted sinuses or things like that, we can do all of that. But we treat these very importantly, have to be treated just like any severe traumatic brain injury. Penetrating injuries can happen. This is a ballistic penetrating injury. Here's another example of a nail in the head. So here's the left frontal region, and this guy was climbing up a ladder at a construction site, and a colleague of his was actually climbing down another ladder, and his nail gun went off right into this guy's head. Fortunately, it wasn't causing any significant injury to any vasculature in a favorable area where we removed the nail. But the patient unfortunately did have a baseline seizure disorder, which kind of got exacerbated, unfortunately, from this penetrating injury. So severe traumatic brain injury is something that we've developed guidelines for the management to try to standardize the care. Because interestingly enough, a lot of people in the past have sort of applied very haphazard management to manage severe traumatic brain injury. Other than surgery, a lot of the management is intensive care management, and we want to standardize it so we can keep oxygen flowing to the brain. And that's so instead of thinking that people are on a will to live protocol, which is the way it used to be, we now have put some science into this. So this step 2 is now more explicit because we really do need to pay attention to various things. Again, airway, breathing, circulation, a patient being on a ventilator, placing monitor to measure the brain pressure and perform surgery on large hematomas. So this is very important. Here's an example of a subdural hematoma case. I just want to put, we have drills, but every once in a while, if the power goes out, you may have to resort to the old Hudson brace, which is the old way of trephining the skull back in the 1950s, 60s, 1960s and below, to drill holes. Our drills failed. There was no power outage, but we had to use the Hudson brace. So sometimes you have to go back to old times. I don't think we're training people enough on old-fashioned, austere cases, because certainly in austere situations, like in developing and low income countries, they may not have all of this, the equipment that we're used to in training in high income countries that do have access to a lot of advanced technologies. So here's a craniotomy. This is the dura right here, and this is a very large acute subdural hematoma in that patient. And so we're just opening the dura here, and we're just showing the clot, and we're going to be taking that thing out. Usually we put it in a bucket and send it to pathology. And then here's an example of a decompressive craniectomy. What we like to do is to try to do a craniectomy so that we could uh, get give more room. Here's an example of a patient with bifrontal contusions. So this way we have take off the both bilateral frontal bones. So this way we can then give more room for these contusions to flourish. So the decompressor, here's what it looks like on a 3D recon. This is a drain, but that's the defect, a bifrontal defect, sort of a bifrontotemporal decompression. And this is an example of what happens when you have the decompressive craniectomy and it's on one side. Here's a patient who had some midline shift, and then we take off the bone right here and then we do a decompressive craniectomy. But the patient, to allow the patient to have swelling of the brain, not inward to cause shift of the brain here, but outward so that the brain goes outside and you relieve the mass effect on the brain stem. Unfortunately, there are downstream consequences like developing hydrocephalus and maybe hygromas here. And so nothing we do is without risk, but at the time that this patient is we're doing a life-saving procedure, but then downstream, we have to consider what we should do to try to reduce the after effects of this life-saving procedure to try to then ultimately recover function. I often actually put still nowadays, even with the availability of implants, custom implants that are $10,000, $12,000 a piece, I put the bone in the subcutaneous space of the abdominal wall. And this way we could house this patient's very thin, so you could see it very prominently, but it's housed very nicely. And then when you take it out, it actually receives blood supply from the fat layer around the abdomen itself. So this way we see pink along the diploic space of the bone. There's the outer table here, and then there's an inner table, and here's all the channels where the bone marrow is. That's where you get blood supply. So it actually stays alive in the belly, and then you can take it out and put it back like this. Okay, so this is an example of the repair. I do have a little video. I don't know if this is going to function. Let me let me let me go back to get rid of this. No, unfortunately, I can't play this video. I was going to show you how to do this thing, and unfortunately, it's not working for me right now. Um, no, sorry about that. I apologize for that. But I want to give time for questions anyway. But this is really the technique where we actually transpose. This is the temporalis muscle, and then here we go on here. We tack it up, so we're recreating the position of the temporalis muscle as it existed over the skull. If you trap it under the replacing of the bone flap or the implant, then you may cause chewing difficulty for the patient, especially if they're cognizant and awake. So here's an example of ways that we can augment here. Here's hydroxyapatite cement, which is hydroxyapatite is a component of bone, and we can fill the gaps with that and make it a little more smooth. So I've used that as a component. These are other materials. Well, there's a problem with autologous bone, especially if you put it in the freezer and not the abdomen, that it may have a higher rate of resorption. So you could get resorption of the bone in situ. So that's an argument that a lot of people give. Well, why not just put an implant in there, a custom implant, and just forego and discard the bone? It is an argument, but I think that I like putting the patient's own material in there. And then secondarily, if we don't have that, we can put in plastic. This is polyether ether ketone PEEK. It's a good fit, but these are all expensive. This is a 3D printed, sort of textured polyether ketone. You can see that conforming, but these are really nice because you can get good conformation with reduced gapping. So that's an advantage to a custom implant. And here's porous methyl methacrylate. I like it because it kind of it is porous. Fluid can interchange and actually can promote some ingrowth of scalp to try to help secure this, although it's never going to fuse to the bone. The problem is that it also can be more fragile. This patient had a implant that was put in. Well, I don't think this is the same patient, but we'll pretend for the moment that this is the next patient. This patient had an assault of a comminuted skull fracture, needed to have this bone removed, ultimately had a cranioplasty with this implant. Then the patient went out back home and had an assault to the same area, came back with this fractured implant. And we put the duplicate that we get, a spare, we put the spare in there. But, again, it's a little bit more fragile than other materials. This is porous hydroxyapatite, so it's sort of like a ceramic where it's heated and conformed. But what happens is that this could actually be osteoconductive, where you can actually have growing in of bone from around the edges and have that incorporate. So here's an example of where you see sort of this gap in between here, like a gray line. Now that gray line is disappearing because now you have made some ingrowth of bone into this implant. So this is the one advantage is more, say, organic material kind of implant. And I've used this especially in patients who I can do it electively because it's it takes a few weeks to get it because it's custom made in Italy. But it's very nice. Even if the patient had some prior infections, this is a good implant to put in. And you could also use titanium as a plate, or you could use a polished titanium, as we've recently done in this particular patient right here. And then there's also this is actually a translucent plastic implant that you can actually use ultrasound to look at the brain through this implant. So that's a nice thing about this particular translucent sonographic type implant. So just very quickly, we can monitor our intracranial pressure. It enables us to measure perfusion pressure of the brain, which is the mean arterial pressure minus the ICP. Because if you have a low perfusion of the brain, you could get low blood flow, which can increase ischemia or decrease oxygen, and increase in the brain swelling and tissue pressure, and increase in the ICP. So severe traumatic brain injury is really about targeted therapy, raising blood pressure when it's too low, increasing oxygen, because we can also monitor brain oxygen. What this represents is that there is a closed cavity with three components: brain, blood, and CSF. And if you could go along just fine adding to what's in a closed skull cavity, but you get to a critical point that if you add a big blood clot, then for whatever small amount of increase in that blood, you get a significant rise in pressure. And so that's why we can drain CSF with a ventriculostomy, and this is the ventricles, and a tube goes in there. And you could also measure the fluid pressure within the brain. And that's a good global measurement of pressure in the brain. This is an example of a patient that we're treating with an external ventricular drain. Here's a canister at the end. And we've got lots of treatments, and these patients are undergoing significant intensive care. And here's then a pinpoint monitor, like a parenchymal monitor that can put into the brain tissue itself and give you a more local um, uh, uh, estimate of the blood or measurement of the blood pressure. As example, this is a relatively old machine, but it's giving us a pressure of 22, which is at the threshold where we would want to treat that. Anything from 0 to 22, we don't treat. We try to lower ICP when you hit 22. So I'm going to just go, we talked a bit about this. I'm just going to go brain oxygen monitoring. If the oxygen is low, we can increase the oxygen that's going through the ventilator. We can increase the blood pressure to perfuse the brain more. We can consider blood transfusions if the patient has, some anemia. And these are the types of monitors we can use. This is a intraparenchymal monitor that actually goes in, which has multiple ports in it. And this is an example of that being put in as a bolt into the skull. And then here we have another type of monitor that measures not only intracranial pressure, but also brain oxygen monitoring. And it's sort of in a little bit It's just a one tube, one time thing. So we've actually been using this one a little bit more, simply because it's sort of a little easier to put in. And that's the technique for putting that in. And this is from the website. They actually give you the instructions. I don't recommend doing this at home though. So this has to be done with training. So but it's a very excellent monitor for monitoring oxygen and ICP. So we want to maintain good oxygen delivery to the brain cells. This is going to go a long way to prevent or minimize the secondary injury. So the primary injury is when you have the impact. The secondary injury is thereafter, because as the brain swells from that impact, you could reduce oxygen and you can get an inflammatory response, and all of that affects cell function and can lead to cell death. And what we want to do is prevent cell death, brain cell death, because we need our brain cells to function. The goal, even for severe traumatic brain injury, is to resect as much brain as to prevent as much brain cell death as possible. Resect if you have to resect um, masses to have that surgically, but then the critical care management is really very important afterwards. And so neurocritical care is also a subspecialty of neurosurgery, not just neurology and not just internal medicine or ER medicine or anesthesia. Neurocritical care, neurosurgeons do train in that. And because we have a perspective, the surgical perspective, it gives a unique perspective on neurocritical care. So if you're in neurosurgery residency, you can do an enfolded fellowship in neurocritical care for a year and get a focused practice recognition for that critical care training and be able to practice as in critical care along with a neurosurgical practice. So that's a possible plug for a possible career opportunity as a neurosurgical subspecialist. So I think that's the end of this show. I'm gonna clear out this thing and stop sharing. And then if we have time, we have a few minutes to answer any questions that you might have.
Yeah, somebody had asked, why is the Onyx system a popular choice for middle meningeal artery embolization?
Onyx. Okay, so onyx is a very viscous um, metallic embolization material that is uh, when you put it in, it actually, and it's being used for AVMs, arteriovenous malformations, a lot, simply because it is so viscous, when you embolize an AVM with that, it actually can spread further into them embolization so that over time you get a more complete embolization that's not just the immediate embolization, but over time you can actually obliterate a lot of the AVM because of this material's viscosity. And so the viscosity of material is also good because it's visible, it can spread and create more of an embolization after the initial injection. When we do surgery for people who have had a middle meningeal artery embolization, you can actually see the onyx as dark on the dural surface, and it's interesting and it's very effective.
Yeah, thank you. So another person had asked if GSC would still be used for patients with Alzheimer's or dementia.
Well, Glasgow Coma score is usually used for acute trauma because it's sort of provides a decision-making tool, and it's not used for more chronic alterations of cognition, such as Parkinson's disease or Alzheimer's dementia or any other types of dementia. They have other scales for that, and I think that that's more appropriate here. It's really in the acute care, and we can use GCS for like acute strokes, along with the NIH stroke scales. The Glasgow Coma score is part of that actually, but you use that to get a sense of where the patient stands in terms of their severity, and that will indicate what you're going to do to treat. For head injury, if they're a GCS of 8 or less, we know that patient is not awake enough. They're too comatose to protect their airway. So they may have a gag or a cough, but they may not be able to really prevent aspiration because they're not cognizant of what's going down their throat. And they may be at a point where they have diminished gag if depending on the injury. So we intubate those patients. So that number tells us we need to intubate that patient. So that's a treatment decision based upon the Glasgow Coma score.
Yeah, that makes perfect sense. There was another question kind of talking about how you avoid sepsis when the brain is open. And to that, somebody had asked about what you do about the blood loss. I believe they had asked that when you were presenting the case of the gentleman who got hit with the chair leg. So if you want to just kind of talk about, I guess, that process.
So, sepsis, the one thing, especially with penetrating injury that reduced sepsis was administering antibiotics. And that's really key. The way we reduce sepsis from any kind of surgery is, especially for an open injury like a penetrating injury, is you must give antibiotics, and those injuries require a course of antibiotics. You don't just give a one time on that. You give it like a week's worth of antibiotics. But in general, for surgical, to prevent surgical infections at all or sepsis from any kind of injury, we give antibiotics for the case, and then we wash things out really with irrigation, with saline, and then we also sometimes apply a dilute betadine solution to it. Some people use antibiotic irrigation, but that's really not been shown to really be that effective because you're not keeping the antibiotic there, you're washing it away. The antibiotic needs to sit. If you're going to add antibiotic, we have other things like vancomycin powder, but we don't put that on the brain because that could have some irritating effects. So we do that a lot in spine Vanco powder. So yes, but the key to any penetrating injury is really giving the antibiotics, and that actually reduced the sepsis rate from these injuries dramatically when that was instituted. And that's an old thing, like 50 years we've been doing that, and that's been an important aspect of our care for those injuries. What was the second part of that? I'm just trying to get
They
that.
were talking about what you do about the blood loss that's experienced.
Oh, okay. So yes, blood loss is a very important aspect because we can lose a lot of blood in acute trauma. Everything's kind of irritated and things like to bleed. I don't know, the scalp bleeds more, everything bleeds more in trauma. When we open the scalp, we give lidocaine with epinephrine. The epinephrine is supposed to constrict blood vessels. You're supposed to let that sit for a little bit, so that it actually has an effect. The lidocaine is really for like a pain management, essentially. That's one way of trying to reduce blood loss. But there are times that we have to use hemostatic agents, such as thrombin in like a gelatin sponge or in a slurry of gelatin that we use and that thrombin can be extremely effective. We have other types of agents, such as like a fibrillar collagen that also helps. We can administer things like intravenous tranexamic acid, which is which is a thrombotic agent. Okay, it's a thrombotic agent that allows blood to clot, and you could actually have very clean surgery with drugs like that. But you have to be careful if you have a patient with a known history of thrombotic disease, like heart attack, or that may not be the best choice of agent. But in a life-saving situation, if you're really bleeding out, you have that choice. Then you also give factors like FFP, fresh frozen plasma, or other factors, cryoprecipitate. These are blood products. To avoid blood loss, you have to try to work quickly, and you have to try to get hemostasis as quickly as you can. Sometimes if you get into the superior sagittal sinus, or a vein that's going into that, that could cause a lot of bleeding. You have to like pack that and try to hold pressure. Sometimes holding pressure with a lot of these thrombotic agents are important. So it's a very complex thing. That's why neurosurgery is a 7-year program, honestly, because hemostasis can be quite challenging, along with all the rest of the stuff that we have to do for the reasons that it's a 7-year program. But not everybody is is adept at hemostasis. You're not. That's not something that you learn. Like you're still learning that even when you graduate. So I'm just saying there the most important thing is maybe upfront giving some of these thrombotic agents and then being careful, but sometimes traumas don't let you because of the how unpredictable even sometimes the nature of that surgery can be.
Right. Yeah. One more person had asked, out of the implants used, and depending on the severity and nature of the patient's condition, is there a particular one that you've seen a considerable difference in recovery times or that you yourself tend to gravitate towards?
So that's a very good question because I don't think that anyone's demonstrated that there's really a preference of one implant over the other. So a lot of these implants, some may have a slightly higher infection rate than others, although infection is a potential problem. The autologous bone flap that I prefer and I store in the belly does have a resorption rate, but when people store them in the freezer and they become devitalized, I think the absorption rate may be a little bit higher. Now, there have been some studies that sort of refute, that. And so, but a lot of the studies that were done with autologous bone flaps are done with freezer bone, or they don't even specify the way the source of storage. But many people freeze them in sub-zeros. We're talking -70 freezers. But that's devitalized tissue. When you keep it in the abdomen, and I put those back, they tend to do just fine. Some of them might absorb a bit. Some of them have absorbed one or two may have absorbed more. But that could happen. So that's my preference because not that I have to, well, I don't know. We all should be cost conscious, but it is the least expensive, honestly. The other ones are really very expensive. But the advantage to implants, custom implants especially, is because they are form fitting. And some of the gapping that you get from autologous bone, if you don't fill it in with the hydroxyapatite, you won't get with those custom implants because they're really form fitting. They're like a jigsaw puzzle piece. What can happen with bone is it can resorb in the belly, right? And it can resorb in the belly and then you may have to reconstruct it when you're putting it back. Anyway, I think Dr. White is ready to give his talk.
Yes, thank you so much, Dr. Ullman. If everybody can say thank you, and we're excited for when you come back to talk about women in neurosurgery. So I look forward to seeing you again. Everyone, if you can just say thank you to Dr. Ullman. It was a very interesting talk. I know I learned a lot.